And we're looking very specifically at how to work better across our lung cancer pathways to understand health literacy and how making this a real focus of our approach in terms of improving the access to, experience of and outcomes from our cancer pathways will have a profound impact on people on that suspected lung cancer pathway. So I'm absolutely delighted to be able to deliver this session with our regional experts, Emma Davison, who's programme lead for the North East North Cumbria Health Literacy team, and Yo-Yo and Kia, who'll be leading our training for us all today. Myself and Lucy have been working alongside them on several aspects and several pieces of work on the lung cancer pathway and learnt tons from them. So it's been really helpful and delighted to share it with all of you. And we've got an example of how we're embedding this at place in one of our trusts at Gateshead. And we've got our Health Inequalities Programme lead touching on some of the health literacy themes on the work she's doing there, Caitlin. So thank you all for joining. The next slide, please. And so we all know lung cancer is a disease really closely linked with socioeconomic deprivation, and the most affluent areas in England, you can see in the bottom green incidence there, have an incidence of lung cancer of 50 per 100,000. Well, we're nearly double that in Nenket, 93.6. So it's a real real issue in our area, in our poorest communities, and that's even higher if we look at our most disadvantaged postcodes, IMD 1 and 2, the incidence nearly 3 times that of the England average. So we knew it's a huge population level problem, and it is intimately linked with socioeconomic deprivation. Lung cancer is our leading cause of cancer death for both men and women, and really understanding the circumstances of the population that we're trying to help within our clinical services is pivotal to how we do things better for them. So next slide, please. So we've been able to work as a Cancer Alliance to really prioritise that, recognising leading cause of cancer death, a huge source of inequity, and understanding the challenges people face on the pathway, that we're working as an alliance to develop and deliver a lung cancer strategy. And even at the outset of developing that strategy, realising that we need to make our communications and our proposal, or even our strategy documents, accessible to everybody who needs to understand, who will benefit from understanding the process we're going through there. So our strategy documents gone through readers panels and PPI teams to make it a universally acceptable, accessible document. And next slide, please. We've therefore been able to collaborate really closely with our ICB colleagues, and the next couple of slides as well, please, who have used the same population health data to map out population health needs and realise that lung cancer is a real priority area, and addressing that through a health inequalities lens and considering health literacy as we take patients on that journey with us is really, really important. So this is the culmination of a piece of collaboration between Northern Cancer Alliance, North East North Cumbria ICB and their specialist health literacy team. And really, you know, our strategy covers all aspects of what is a very complicated diagnostic and treatment pathway. Unless we can communicate with the people who are on that, what's happening to them and why and what the steps involved are, we will not get good access fairly for all of them. They won't have a good experience when they're going through a complicated pathway, and that's why we see worse outcomes. So this collaborative piece of work between us all is really crucial, and so I'm so grateful to be working with the team. They're going to take us all through an awareness session on health literacy today, and I'll hand over to Kia and Yo-Yo to do that. And then as we come to the end of that piece of the work, we'll just share how we're doing it at place. So I think I've covered this. We've done we've worked with them more closely on a couple of specific areas. They've really helped us to understand the complexities of making thoracic surgical decisions. So we've got a specific piece of work in the pipeline on a thoracic surgery leaflet. The lung cancer nurses at Gateshead, as part of the place-based work, have benefited from the specialist health literacy team in developing our lung cancer nurse patient-facing information leaflet. And there's an ongoing piece of work looking at how we're reviewing our appointment letters for CT and outpatient, and we can share that as we come to subsequent sessions on how to write simply and speaking simply, sort of real examples that we could take back to our places and implement, so that at the end of this and this series of webinars, we've got a really robust suite of training resources and patient-facing information for those on our lung cancer pathways. I think that's me. Thank you.
Great, thank you very much, Ruth. And we'll hear from Ruth again a bit at the end with a bit more of the detail on that. But for now, hi everyone. My name is Kia Thomas, and I'm one of the health literacy trainers on the regional health literacy team. And I'll be doing the first part of this health literacy awareness session, and then I'll hand over to Yo-Yo Kwan to deliver the rest. So we're going to have a look at the basics of what is health literacy. Some of you might have seen some of this before, you might already know this, but it's just to make sure that everybody's on the same page about all of it. We'll look at who it affects. We'll talk a little bit about why it's a problem. And then we'll talk about what we can do about it and what we are doing about it. So this session is meant to be quite interactive. There are bits where we really need your input and your insights. So we'd love you to join in as much as you can. You can pop answers in the chat. That would be great. It's a place to unlearn and maybe unlearn some things that you already thought or believed. And with that in mind, there's no silly questions and no silly answers. So if you have thoughts, pop them in the chat. If you have questions, pop them in the chat. We can't guarantee to get to every point in there because we do have a lot to cover today, but we will do our absolute best to monitor what's going in there and answer what we can. And this session should be relaxed and safe, so we're going to be kind and respectful to everyone, obviously. So before we get into that, we'd really love to know what you think about your current knowledge of health literacy. So no judgment at all here, just we want to figure out where we all are, where we're starting from. So if you can, in the poll there, rate your knowledge from 1, you know, nothing, 5, heard this all before, just here for lunch. So if you can submit your answers, that would be lovely. Right, Oh, I thought I had my screen set up right, Yo-Yo, and I don't to see the results. Can you?
No worry, the average
Can you
is
tell me
around,
where we're at?
no worry, the average is around 3.1 right now, and then 40 people submitted their response.
Brilliant. Thanks very much, everyone. So 3.1, great. So we're sort of high end of the middle there. Brilliant. If you can keep that number in mind, because we are going to ask you again at the end of the session, and hopefully it will have gone up a bit. So we're going to start the session with this video that our team made. We're going to show you part of it. And it's just sort of to give you a little bit of a flavour of what we do and why we do it. Right. Does anyone have any thoughts about that video? Anything that makes you feel, anything surprising in there? If anybody wants to pop anything in the chat, or if it's easier for you to just speak up, then feel free. We'll see how quick my Wi-Fi is today. No, nothing to share. That's fine. If you have any other thoughts, just pop them in, and we'll have a look at them. So what we'll move on to then is, what is health literacy? Pretty good question to ask in health literacy awareness. There are a lot of definitions of health literacy. There are sort of over 200 different ones. Here's one of them. I would like you to have a quick look at this, please, and then if you can tell me what it says in your own words, please. I'll just give you a minute to look at that. Does anyone feel able to summarise that for me? No? Okay. That's not really surprising. Let's ask a different question. How did trying to read that make you feel? Frustrated, confused, another confused. Yeah, perfectly reasonable feelings to have. What it must feel like for someone with dyslexia. Yeah. Yeah. Obviously, like you didn't really stand a chance of understanding that because it is all mixed up. And the point of this little exercise really is just to say that these negative feelings, confused and frustrated, these are how people very often feel when they are given health information. And nobody put their hand up and said, hey, what is that? I don't understand it. And that's how people, again, feel when they have health information. They might be really confused, frustrated, completely lost, have given up on reading it, but they might not feel able to tell us. And so the first step, if we want to make any steps towards improving health literacy, is just everybody recognizing that is how people often feel. So let's have a definition we can actually understand. Health literacy, according to the World Health Organization, is the ability to access, understand, check, and use information to make choices about health. So you can see from this definition that it is about more than just people being able to read. People need to be able to get hold of information in the first place. Can people access health professionals, GPs, to tell them things? Are they able to get on the internet to find the NHS website? Can they understand that information that they're reading? Do they understand all the words on their cigarette packets that have the cancer warnings? Do they understand what it means when they're reading a list of symptoms and it says they have a persistent cough? Do they know what that means? And then it's been having the critical skills to be able to check the information and figure out if it's up to date, if it's reliable, or if it applies to them. If somebody's got information, do they know how to check that it's from the NHS website? Is that reliable? This is some random person on TikTok giving me cancer cures. Are they the same type of information? And then it's about being able to use that information to make choices about their health and well-being. And that could be something as simple as what ingredients I put on my shopping list if I want to live a healthier lifestyle, to, what do I need to know to have this life-changing surgery? So health literacy is actually really quite complex, and there are a lot of different things that feed into somebody's individual level of health literacy. The first one is personal characteristics. We do know that some people are more likely than others to struggle with health information. And we're going to talk about those in a bit. But it's not just about the person, it's not just about the individual, because we all live in a context. And that context really matters. For example, the social resources that somebody has access to can play a big role. And that's things like the friends and family and the network around you. And it's also things like money. Can you afford a phone? Can you afford an internet connection? Somebody who has a job and can afford reliable internet and is surrounded by family and friends and community who can help them out, they've got a lot more social resources to draw on than somebody who is isolated, who doesn't have any money, who can't keep hold of technology for whatever reason. And then there's a bigger picture too, and that's the society and the environment that people live and operate in. And that includes the healthcare environment. And what's really important to remember is that this healthcare environment, the healthcare system, it doesn't just exist. The way the world does, it's something that's created. And it's created by people like us, the professionals working in it. So maybe that means that we play a big part in how easy or difficult that healthcare environment and the information within it is to navigate. So thinking about that healthcare environment and the information we share, it happens in lots of different ways. It happens by speaking in person or over the phone. It happens in writing through letters and leaflets and other documents. It happens online, increasingly more online nowadays. And it also happens through the physical environment. So that's things like the signs in a building. So just thinking now across about the lung cancer pathway and when we share information on that. When, as part of your role, are you sharing information verbally by speaking? What kind of information are you sharing and how does that work? If we can just have a little chat about that in the chat. When are you speaking to people and what kind of information are you sharing? Anyone? Is everyone feeling shy today?
Hopefully they are eating right now.
Oh, is everybody eating? I'm jealous.
Oh, Joe has some sharing.
So you're helping to support people affected by cancer, telephone face to face, giving information on investigations, both before and after, telling people they need to come for tests, having clinic consultations. Yeah, so you're talking to lots of people about tests to find out what's wrong with them. Some of those tests quite complicated, have a lot of risks in them, don't they? Sharing support and guidance needed more in the community, supporting clinic appointments and chemo and radiotherapy units. Yep. So some really quite complex situations that people are in then. What about writing? Whose job is it to share written information? I guess there's probably people get a lot of letters along this pathway. Is that fair to say? Letters with presumably some of these test results might come in writing as well as or get backed up in writing, I think. Yeah. Yeah, information leads, written information about the investigations. Yeah. Give information back. Yeah, there's a lot for people to take in, isn't there, about all of these various tests and treatment options. So yeah, we've talked to some cancer patient groups before, and they said, you get a huge chunks of information, especially on diagnosis. So you get written information in the consultation to parents, yeah, like clinic letters and stuff like that. Yeah. Is there a lot of information online that you're responsible for or direct people to? Which can be quite difficult sometimes in it, knowing where to direct people. There is a lot of information online, and this is the thing we find at the minute. People are seeking out information sometimes when they don't understand it from other sources, and that's not always a healthy thing for them to do. Yeah, lots of wide range of formats online. And then when we're looking at the physical environment, I think there's a lot of different venues potentially involved, isn't there, across somebody's cancer journey, and hospitals are not known for being the easiest places to navigate. So QR codes, yes, some patients do find QR codes very difficult. I think they're so ubiquitous now, we forget they're actually a very new technology, and some people need a bit more help to get used to them. But yeah, in the physical environment, there's obviously signs around our hospitals and our clinics that people are having to see, and sometimes they're not always as easy as they could be. So just thinking about all that information, there's obviously a lot of variety there as people go through various stages in this journey. And different ways of sharing information need different techniques to make them easier. But the thing that they all have in common is that some people, with the best, no matter how much you try, are going to struggle to understand that information. So let's have a look at who these people are. You know, who is affected by low health literacy? And so there was a study about 10, 11 years ago now by a local GP called Jill Rowlands. And she looked at the personal characteristics of people in the region and who is more likely to be affected by low health literacy than others. And it found that men are more likely to struggle with words and women are more likely to struggle with numbers. It found that our levels of health literacy are likely to get worse as we get older. And people from minority ethnic groups or people born outside of the UK or whose first language is not English, that they can sometimes struggle. Also characteristics to do with education and work, and people who have less money and live in deprived areas more likely to struggle. And since that study was done, we also know that learning disabilities and mental health problems, which we don't always know much about when we're encountering patients, they can have a real big impact on how much somebody understands as well. But as for the scale of the problem, what percentage of adults do you think could be affected by low health literacy across the North East and North Cumbria? Anyone could have a guess? $40, $30? Yeah, they are 35. They are not bad guesses, but actually, if we're looking at health information that contains both words and numbers, we estimate that 62% of adults in the region could struggle to understand that information. And we get that data from a geodata tool that Yo-Yo's just put the link in the chat for, that can tell you the health literacy rates for various the council areas across the country. And that was developed based on the same work that we've just talked about that identified those characteristics. So, you know, and we use words and numbers because most health information contains numbers in some way. You know, you've got appointment dates, times, dosages, risk percentages, that kind of thing. So 62%. It varies across the northeast from 58% in Northumberland and North Tyneside to 68% in parts of Teesside. And that's in most areas, that's higher than the national average of 58%. And so in parts of our region, that's, you know, 2/3 of people are going to struggle to understand the health information we give them. So that's a massive problem. But it's sort of who is affected by low health literacy is a bit of a trick question, because really everyone can be affected by low health literacy at some point in their lives. Our ability to take in information and use that information is not a fixed thing. It varies across the course of our lives. You know, the data showed that health literacy gets worse as we get older. But more than that, just on a day-to-day basis, we don't process things the same. It doesn't matter how, you know, educated or how literate you are. If you're tired or you're overwhelmed or you're stressed or you're unwell, your ability to take in information and understand it can really drop. And obviously, people on the lung cancer pathway very possibly feeling all of these things and more. When we've been out and we've talked to cancer patients about this, they have said, when you get a diagnosis, it does just numb you and you can't take in anything, but you're being told an awful lot of important things. So really, it could happen to any patient on any pathway at any point. And why is that a problem? I've got a little story that sort of illustrates some of the problems. So a gentleman went to see his GP with chest problems. And the GP examined him and said, right, we're going to send you for a chest x-ray. Come back and see me when you've had that. So he made a follow-up appointment. And when he came back for that follow-up appointment, the GP said, well, I can't see your x-ray on your file. He said, oh yeah, I didn't have it. She said, okay, why? And he said, well, I got sent the letter and it told me when my appointment was. And I went to the hospital and I couldn't find the x-ray department. There were no signs for it anywhere. And I couldn't find anybody to ask. So, I walked around for a bit and then I just went home and then I came back to see you. And so because he didn't realize that he needed to be in radiology, the letter he hadn't made that clear, and he hadn't been able to see signs for where he thought he needed to be. That appointment in radiology was wasted. He had to make another x-ray appointment and then another GP appointment, and that all delayed his treatment by a few weeks. So that's just a little example of how it can cause problems. It can cause problems for individual patients and the public. It can cause problems for staff who are dealing with those patients, and then it can cause problems for the wider organisations. And so if everybody's eating, I'll probably just try and go through most of this myself. But do feel free to pop anything in the chat if you've got a spare hand or you've got a particular thought. So low health literacy causes problems for patients and the public, for those people who are having the health problems. Because, if they're struggling to understand a letter that tells them where their appointment is, that means they are more likely to not be able to get to that appointment or to miss it, or to come to it unprepared because they haven't understood as much of the information as they should. And we know that adults who have low health literacy, and not just those adults, but their children and their families, suffer the worst health outcomes in society. They are more likely to die younger. They're more likely to have multiple health conditions, more likely to miss appointments, less likely to engage in public health campaigns like vaccinations or screening. So all of this adds up into getting treatment later, not being able to comply with the treatment as well. All of this adds up to poorer health outcomes, which is obviously a problem for those people. But it has knock-on effects too for staff. And again, feel free if you have any personal experience of this. If people are coming to you not having understood all the information, they're going to need you to explain that. Again, they may miss appointments. They may show up for appointments unprepared. You may have to spend a lot of time explaining something you've already explained. And this compromises your ability to do your job. You're having to spend a lot of time redoing things, and as well as affecting the quality of the care that you can give. That also can have an impact on staff morale and job satisfaction. We're only human. We can feel frustrated. And that really does impact on your own mental well-being. And then it's a problem for the organisations that you work in, because there are huge knock-on effects there. Low health literacy costs money. One study in the US estimated that low health literacy can cost a healthcare system up to 3 to 5% of its annual budget. So obviously we're talking about the NHS in England. That is a huge amount of money. It's billions of pounds. It's through wasted medication, missed appointments, more having to give more expensive care, that kind of thing. It's also a safety issue. If you tell somebody, if instructions and they can't follow them, we don't know that they're following them at home, not sure that they're getting the right treatment. If they don't know to tell us about things that we need to know, allergies, prior conditions, that kind of thing, that may be we're not able to give them the right care. It means services aren't used in the most efficient way. We know that people with low health literacy are more likely to go to A&E for something like a stomachache, for example. And all of this is basically putting a lot of pressure on a system that's already under a tremendous amount of pressure from all angles. So we need to do something about this. And if all those problems that it causes for individual patients, staff members and organisations aren't enough, there's an even bigger picture. Because if we come back to these people who are more likely to be affected by low health literacy, and this is something Ruth mentioned in her introduction, you'll see that a lot of these groups are often the people who are most badly affected by other problems in society and in healthcare. Which makes health literacy a health inequality, which are unfair and avoidable differences in health access, experience and outcomes. So having low health literacy means you are more likely to have other health inequalities, and it works both ways. Health literacy sort of is linked to them, but it also can cause the worst health outcomes. And this map on the right is just a map of health literacy levels across the country. And there's quite clear north-south divide there. Health literacy levels are much higher in the south of England, with the exception of central London, than they are in the north. So straight away we can see the inequality there. And then we have this map as well. So on the right is either the same or a very similar map to the one Ruth shared before of lung cancer incidence rates across England. And we've got the northeast circled on there. You can see there's lots of dark areas where the incident rates are worse. And on the left is the map from the GeoData tool that I mentioned before that shows the levels of health literacy across the country. And the red and orange areas are the areas where there is lower health literacy, worse problems. And it's not a perfect match, but you should be able to see that a lot of those red areas on the health literacy map coincide quite neatly with a lot of the dark areas on the lung cancer map. There's a lot of correlation between not just lung cancer, all kinds of health problems and low health literacy. So by tackling one, we hope we can help to tackle some of the other inequalities as well. And now I'm going to hand you over to Yo-Yo.
Thank you, Kier. So hopefully you know more about the background and the problem of the lower health literacy. And then, yeah, you can still enjoy your lunch, but if you have any questions or idea, please feel free to just put it in the chat. I know some of you may be multitasking. Okay. So anyway, good news is we can do something and to tackle about that. So one way to improve health literacy is on your left-hand side, by upskilling individuals and communities, we can help them to build up the skills and confidence to understand the health information. That is very important and it's a good idea, but everyone have different priorities and it is quite costly to run the courses for everyone. It also takes a long-term time to see the results. Another one on your right-hand side is recently we have recognized that organization and system play a big role in addressing the problem. So there's a lot we can do within our control, starting with the information we provide. So as a healthcare professional within the system, if we can make our information easier to access, understand, check, and use, it is relatively easy and quick, and everyone can benefit, not only the patient, also the staff, the organization, even the wider system. So in the lung cancer pathway, information is often shared quickly, repeatedly, and by different teams, from first test to diagnosis to the treatment decision. So let's think back what Kia shared about earlier, and then what you share about the information in your role as well. So keep those in your mind and think about which technique you would apply in your job role. where the clear communication could reduce confusion, anxiety, or the repeat contents. Actually, we will have a specific section for speaking and writing, but today we will go through some very quick and easy tips with you first. So are you ready? So just give me a thumbs up if you're ready, okay? Even though multitasking. Do you know the emoji at the top? Can you give me a thumbs up? Not ready. Oh, thank you. That's good. That's good. Thank you. Yeah, great. Let's move on. So let's start with speaking. Chunk and check and teach back are very useful technique. They help people follow what is happening right now and how you check the understanding. So first of all, try to break down the information into small bite size using everyday word. After each chunk, pause and check the understanding. Because many people may say that, yeah, I know everything, but actually they don't. So try to ask them to repeat what they understand in their own word. For example, what they understood, what they will do next. Yeah, remember that is not the memory test. It is the way to understand how you explain the things, okay? So I'm going to share the pictures for you to visualize how it looks like. So on your left-hand side, if you give too much information at once, people may feel overwhelmed. They may not know where they missed the things, but they just get lost, isn't it? But on your right-hand side, if you break down the information into different parts, and then after each part, you can pause and then allow them to ask the question. You can also check the understanding as well. It will be easier to spot out, and then you can clarify as soon as possible. And then we also encourage the patient to ask the questions, because once they feel confident to know the things they are working on, doing, and then they are more willing to make the informed choices and then follow the instruction on their own. So again, we will have a separate session to talk about speaking. It will be scheduled on March. So if you're interested, remember to accept the invite, okay? Next one, that is a writing. You shared a lot. Yeah, you cover lots of written information. That is a very important in the lung cancer pathway. But written information only helps if people can understand and use it. So the key is to keep the simple language. So simple language means you can use everyday word, simple, familiar, and avoid jargon. In healthcare, we always use some complicated word because we are professional, isn't it? But actually, we can keep it simple. So we will give you some example. Instead of nausea, we will say feeling sick. Instead of metastasis. Please forgive my pronunciation, it's quite difficult. So you can imagine the patient may not pronounce correctly, even they may not get it correctly. So we can say spread. Biopsy, we can say sample of cells. Next one, MDT, probably quite common. You know, NHS love acronyms, but we may forget how confusing it could be, especially people who don't have the same background as us. So try to explain the full term first. For example, yeah, if you would like to say MDT, we can say, oh yeah, it stands for multidisciplinary teams. This is a group of specialists who will think about your case and come up with the best option for you. So always write the full term first and then use the acronym later on. Again, we will have a separate section for how to write simply. If you are interested how to write it in better way for your letters or leaflet or any communication stuff, please join us. It will be in February. Next one, there's an online information. I think we share a lot because it is quite quick, convenient, and always available. However, not everyone have internet access. Also, they feel confident using their digital tools. So we need to make sure that no one is left behind. So as an organization, we can help people access the online information, for example, offering options and support, and then help people to get the device. So first of all, write in simple and clear language, give a non-digital options, because as I said, that some people may not have internet access. So it would be good if you can provide some printed copies or phone numbers, even another alternative. And the next one, offer help for filling in online form. I remember one of the colleagues said that, oh, some patient maybe struggle with the QR code, isn't it? So if they are struggle and you realize, you can help them to fill in as well. Next one, you may need to help people get a device to use. So maybe probably during the appointment or workshop, just make sure that people can access the online information. Online information is everywhere now, but we need to make sure that every digital message, no matter a web page, email, or online form, is simple, clear, and inclusive, so everyone can access and understand. Last but not least, the physical environment matters too. So in the clinical setting, we can rename the clinical, we can rename the clinics or provide a better maps so they are clear and easy to follow. So first of all, use clear, familiar words so the size and direction are easy to read and understand. Next one, make sure the department names merge up. I know it may not always be fully within your control, but it's worth starting conversation about that and considering how much influence you have. For example, what Kia shared as X-ray instead of radiology. So make sure that people know where exactly they're going, and then have a good map, use up to date, easy to read, not the old screen capture from the Google Map. Next, make the direction as detailed and as useful as you can. So you can help people with unfamiliar routes or transport and use the clear instruction, like go through the double door, turn left at the cafe. So every small improvement in navigation, you can reduce the stress for patient and visitor, also build the confidence and trust as well. Even you can help people focus on their care rather than just finding their own way. So we know how do we know this stuff? Because people tell us, we go to the community and ask them what they think about our work. And then there are 2 calls from the Northern Cancer Voice support group and tell us what kind of information they want. Let's have a look. First one, stuff needs to be simple to read because it's dramatic getting a diagnosis. Next, information is power. It helps you to be in control more. It helps you tackle the numbness. It is very important. When the information is simple and given at the right level, especially at the point of diagnosis, people feel included rather than overwhelmed. If they are more likely to ask the question about anything they don't understand, which helps them to make the informed choices about their health. That is the key to personalize the care, share decision-making, and fairness of all. In the fast-moving non-cancer pathways, I think the clear communication matters. It saves time, reduces confusion, supports safer decisions, helps people feel more in control during a very difficult time. So every small step you do in how we speak, write, or share the information online or give the direction can make a real difference. So hopefully you found the section useful. And then now thinking about everything we have covered, how would you waste your knowledge of health literacy right now? So take a few seconds. There is a poll question on the screen. Could you please share the numbers? Again, no judgment, just want to know How well we presented, isn't it here? Oh, great. 8 people responded. Okay, now 10. The average score is 4.3 right now. Sounds good. Thank you so much. I'm going to put the section in the chat. So if you are interested to join our writing and speaking simply, please reserve your time. You can accept the invite, or you can also share the invite with your colleagues as well. And then last but not least, we are going to organize the conference, and then it will be on 3rd of March. If you're interested, please feel free to register in the link. I put it in the chat. So we try to share the learning, share the best practice in the event, also hope to increase the awareness of the health literacy. If you're also interested in the PROSA presentation, please also let us know. So thank you so much for your time. If you have any questions, just pop in the chat. We will try our best to answer. And then after the session, we will also share the resources, recording, and the PowerPoint slide with you. So great. Hand over to you, Ruth. Thank you.
Thank you so much, Yo-Yo and Gia. I've watched versions of that training a lot of times and keep taking away different nuggets. I feel I've done good at written communications, verbal communications. I've never challenged our ridiculous signage. I'll take that next. So thank you, really useful. I think it is really difficult when you kind of have this new awareness of health literacy and a better understanding to then think, you know, where do I start with it? How do I go back and sort of improve either our personal approach or our service approach or a trust level approach to health literacy? Like, where do you start? What do you actually do? And you gave us some real tangible nuggets there, but hoping by the end of this session that people might have a think about this. And so we were just going to very quickly share our kind of Gateshead experience. We've been extremely lucky within our lung cancer clinical service, our clinicians and our specialist lung cancer nurses, to have the support of the a team, health inequalities team, our health inequalities program lead, Caitlin Robinson, who I'm hoping is on the call to talk to this a bit with us today, and really looking about the experience of people who struggle to go through a cancer pathway. And obviously health literacy is a really key theme with that. So she's going to share how we're applying that within our Hive team, which is specifically looking at people as they access our urgent suspected lung cancer pathways, and not just learn from their experience, but how to influence and change within an organisation. Are you on, Caitlin?
Yeah, I'm here. Can you hear me?
Yes.
Yeah. Hi everyone. So just to add to what Ruth said, so I'm a health inequalities program lead at QE, and I oversee the Hive team. So just a little bit of background on the team. They're really I would say a specialist team working with people with multiple and complex needs in order to improve access, experience and outcomes in healthcare. And I think what we learned from this is we have a lot of people who should be accessing our services and are eligible to access our services because they have a secondary care need, but just can't get here or for some reason don't attend. So we've really taken the learning that we've gathered from working with people with complex needs, but we've been able to apply that much more broadly and think about actually if we apply things at trust-wide level, thinking about the things we do as our core business, how does that improve the access, experience and outcomes for everybody, but especially those living in poverty with poor education or backgrounds or additional challenge. And health literacy was one of those things that definitely came to the top of our list of priorities. With that, we had intended on our lung cancer pathway, where we started with Hive, to start and look at this, but we were able at the time, our trust were really looking at what should our trust priorities around health inequalities be, and we were able to suggest health literacy and move that up the list of our priorities. So in our organisation, the 3 priorities for health inequalities for this year is health literacy, embedding the reasonable adjustment flag and making every contact count, so really prioritising prevention. If we just go to the next slide, please, if possible. So I think what we started with on the lung cancer pathway was this recognition of all the different points and places in which people you know, they move along this pathway, but also all the different points in which we could lose somebody along this pathway and where people fall through the cracks. So there's been lots of work done with the regional team, and to be able to kind of see that happening around the symptoms and screening for lung cancer, and how we are more health literate in those regards. But also thinking more so around people who are symptomatic, so recognising their symptoms and how they then go to their GP and there's a referral form. How do we get better at recognising where someone might struggle? So if a GP knows that someone can't read and write or has a low literacy level, do they hand that over to us in secondary care? But I think, you know, there's all of these at different points in which we could have processes or procedures that might make the pathway easier, both for professionals and patients. But I think, especially on a cancer pathway, we've, as organisations, we've moved to a lot of things being automated or more efficient, and often that results in a direct to test. So we don't always have the opportunity to speak to someone and understand that they're definitely going to make it here and can get here, and understand the letters that they receive. So from our perspective, we've really started with our appointment letters, because if we don't get the appointment letter right, and people don't know when their appointments are, where they are, what time they are, we don't expect to see them in hospital, unfortunately. So we've really been working, we're very early days, we're definitely still working it out and how we get it kind of trust wide. But on a lung cancer perspective, we're starting to think about how we make sure our letters only have absolutely essential information on. I'm sure everyone here in your respective trusts, your letters will talk about park, and they'll talk about students might be in clinic, they might tell you about something else, but they're probably not very good at actually getting you to your appointment. So really starting with our appointment letters, when we first started this, I ran a couple of our letters through the kind of reading age tracker, and they were up there at kind of over reading age 16 years, where if we're talking 8 to 10, that's, you know, I think was it almost 2/3 of people couldn't kind of read and process that letter accurately. So we're very early, and we're definitely kind of working through this. I'm just thinking if we do the next slide, it'll show. Ooh, yeah. So really thinking around how we do some of the basics. So our appointment letters, our leaflets, as we move in time, changing our processes so that all new written communication has to be considered as a health literate approach, and recognizing that this won't happen overnight. So we won't go from having none of our letters in a low reading age to all of them overnight, but certainly as we're producing new patient facing communications, considering that, and considering all of the information that people receive from different sources. So not just thinking about the kind of physical clinics and the consultant appointments, but working with our teams in CT, you know, thinking about radiology, how do they communicate? Do they also use resources and written information, and can we streamline any of that to make it much easier for people to process? But I think most importantly, and I think this aligns really well with the reasonable adjustment flag, is also understanding if people have a low reading age. So asking people when we see them, can you read and write? And if actually there's any concern there, being able to make a reasonable adjustment. So as standard, we should have a low reading age on all of our outward facing communications, but also understanding that you know, it is phenomenal and it'll help for the vast majority of people, but there'll still be people who won't be able to read and write, and making sure we're capturing that and making reasonable adjustment in that regard as well. Ruth, did you want to add anything to that?
No, I think it comes through in the summary on the next slide, actually. It's about that kind of minimum standard for all being much better, but then being able to offer something bespoke, isn't it? So I think the Hive service, as you've articulated, by walking the path with the patients who've struggled the most, we've really been able to understand where our gaps are. And I guess that's my urge to you within our different services, to really try and learn where they are. And if one person's had a bad experience, make sure you kind of get to the bottom of that and then address it for everybody else. And sometimes it's really basic and quite embarrassing that we haven't cracked this already. For instance, you know, our electronic patient record system generating letters isn't automated in its ability to print a large print letter for someone recorded as visually impaired, or translation. You know, if somebody needs written communications in another language, it's quite a clunky process, and we don't have standard operating procedures to make sure. We might be able to translate a clinic letter and know how we would do that once we've seen them, but they don't get to us because our appointment letters weren't translated into their first language. Caitlin's had people struggling with 24-hour clock, and as she says, letters that are just bombarded with so much information, research active centres, students, parking. There's so many numbers and so much text on there, that they really struggle to see exactly where they needed to be for their appointment. So there's some real basic things that we could all do to get right, and it's about understanding where those gaps are and addressing them. I would urge our starting point to be to learn from those people who haven't attended, like something's gone wrong there. And from our Hive experience, when we've gone out to those people, nobody didn't want healthcare. There was a barrier, and it was often understanding what they were having done, why, where they needed to be. That's all in our communications. That's their level, you know, that's health literacy would address that. I think a second kind of system-wide approach, as we touched on, and building on everything Yo-Yo and Kia were saying before, like the reasons people might struggle with health literacy, whether it's mental illness, learning disability, learning difficulty, low educational level, it's to be able to communicate that. It's often written somewhere in a free text in a GP communication to us, but if our process is that our bookings team just leave letters, like don't extract any information from that and build it into record it in our EPR by way of a reasonable adjustment flag, because they're waiting for things to be triaged and clinicians to accept it. Clinician accepts it and an invitation for an appointment goes out. We've totally missed the nudge to communicate with someone in a way that they can understand. So that kind of how we share information, how we receive it, how we record it, and how we automate doing better is really key. And obviously, as with anything with an EPR, is much harder than we all imagine, but it's pivotal, isn't it? It's crazy that we're not better at it, and we must get better at it. And then I think thirdly, as organisations, we really need to think about our kind of system-wide resource allocation. We, you know, have our people, our workforce, those responsible for sending patient-facing communications, have we really invested in them? Have they had appropriate training about health literacy? Have we empowered them to be able to make these reasonable adjustments and to own the communications that they're sort of responsible for? Are our processes for considering new patient information resources informed and led by a health literacy approach? And this is where we're really benefiting from the regional team coming and supporting us at Gateshead, and especially on the lung cancer pathway. But that's something we can share universally across systems to inform not just what we do with the leaflets we have here, but what do we do going forwards with all our new leaflet approval structures, our governance approaches, and then kind of standard services. You know, appointment booking letters, SMS prompts might work for the majority. Like Caitlin said, if we do them well, then we hope that 60% of them will be able to access them and understand them. But how do we protect some resource to provide that really enhanced support for those who need it most? We've been desperately fortunate to have this high intensity support team on a respiratory pathway. Which other pathways are most profoundly affected? What resource do they need, and what does that look like? So there's a lot to think about in systems. There's also stuff we can just do in our place, our professional role in our services, and within our clinics. So I guess an awful lot for us to think about. On the next slide, please. So we are going to continue to work really closely between the Cancer Alliance Lung Pathway Board team and the Regional Health Literacy team with any places who are keen to come on this journey with us, and we'd love you to. So please do reach out. Really consider what you could influence in your pathway, in your clinical service, in your organisation. If something's leapt out at you and think, I'd love us to be able to do that, then please do share it in the chat, because we can collate and we can work collaboratively on any of them. These sessions will be recorded so that you share with your colleagues, and we'll be able to come back and refresh on them. And as Yo-Yo suggested, we've got 2 further sessions, the How to Write Simply and the How to Speak Simply, which are both really, really invaluable ones. And we'll share the details of those and some lived examples as well. So very grateful for everybody's time. Sorry, a bit whistle stop at the end. I think, is that the final slide, or do you have a further link to the... We've got a feedback link if everybody could possibly complete that. That's really useful for informing the work that we're doing and making sure that we've built in any feedback for the next 2 sessions as well. And I think you had your references and a reminder about the regional day. Thank you so much, Health Literacy team. Really grateful as always. And thank you to people who've given their time today. Very grateful.
Thank you very much for having us, everybody. It's been great to speak to you. We hope to see you at the next session.
Yeah, hope to see you next month.
Thank you.
Bye, everyone.
Thank you.
Bye.
Bye.
Thanks. Bye.